You are live now, ma'am.
Okay. Good evening, everyone. Welcome to another episode of DOS PEP. And I have been traveling across country for some purpose. And what I've realized that you people are liking this PEP concept
You are live now, ma'am.
really well, and
Good
it's
evening, everyone.
helping you guys a lot in your exam preparation. So thank you for logging with us and joining all our lectures. And today we have a very important speaker, a very important topic also. And it gives me immense pleasure to introduce our speaker, Dr. Kumudini Sharma, ma'am, our own alumni from RP Center, AIMS, New Delhi. And ma'am is going to speak on a very important topic,
Us and
cortical
joining all.
blindness, which is very important for your day-to-day practice also. So, ma'am, thank you for agreeing to take this difficult lecture. Now, I will request the coordinator for our program, Dr. Gunjan Saluja, to introduce our speaker, ma'am, and then we'll move on to the lecture. Dr. Gunjan?
Yeah. Very good evening, everyone. So today's lecture, as Sir told us, will be about cortical visual disorders. That will be taken by Dr. Kumudini Sharma, ma'am. She is a professor and head Department of Ophthalmology. She has done her MD from AIMS New Delhi, followed by a fellowship of Neuro Ophthalmology and Medical Ophthalmology from Texas. And she has been formerly senior faculty at SGPGIMS Lucknow. Currently, she is professor and HOD of T.S. Mishra Medical College, Lucknow. She has several awards and publications to her credit. The noticeable ones include the Lifetime Achievement Award from the Indian Neuro-Ophthalmic Society. She is an international fellow of North American Neuro-Ophthalmic Society and an honorary fellow of All India Collegium of Neuro-Ophthalmology. So, ma'am, over to you. We hope that the lecture will be very useful.
We'll share the slides. Good.
Yes.
Screen कर दे. It's full screen. Everyone can see it. Yeah. You can continue. Okay, thanks Gunjan for the nice introduction. So the topic of I would be discussing is the cortical visual impairment. And just before discussing the topic, I would like to discuss a brief neuroanatomy of that reason. As you know, the primary visual cortex is the area 17, is in and around the calcarean sulcus. And they can see you. In and around the calcarean sulcus on the medial side of the occipital lobe, and it receives inputs from the lateral geniculate body, and this is called genicocalcarean pathway. The small part of this primary visual cortex extend on the lateral surface of the brain near the occipital poles. The neuron in the V1, they respond, like we know as the retinal ganglion cells and lateral geniculate body ganglion, their receptive field is a circular one. While the neuron of the primary visual cortex, their receptive field is a more of a linear one. And they respond to the orientation of that line and to the edges, also the contour, and to the motion when the streak moves to the one side to the other side. Some of the neurons, they fire on when the streak in the receptive field move to the right side, and some of them they fire when streak and the streak of the light move in the receptive field to the left side. So they are directional sensitive also, and some of them they respond to the depth also. So this V1 area, the primary visual cortex, gets sends its input to the extrastriated area, the 18, 19, which are called visual associated area. Not only V1 sends its input to the 18 and 19, it sends its input to the V5 area, the middle temporal gyrus. It's not moving. Oh. Just a minute, okay. Stuck again. And now from the V1, this is the second one. From the V1, we know there are two parallel visual pathway. One is a dorsal one, and another is a ventral one. The dorsal one is the where pathway, which is also so mainly there is a visual special perception, while the ventral pathway is the what one, where the visual responsible for visual recognition of the stimulus. So the dorsal one pathway is a project to the from occipital lobe to the parietal lobe, and it mediates the spatial awareness and the motion perception and the visual attention. While the second one, the ventral pathway is a response, it projects from occipital lobe to the temporal lobe, and it mediates object recognition and face recognition, color perception, and the shape of the object. There, besides this geniculocalcarian pathway, which is major visual pathway, there are alternative neural pathway. They bypass the V1. They don't end into the V1. These are some of the fibers from the retina. From the optic tract, they go to the superior colliculus. From there to the pulvinar of the thalamus. And from the pulvinar of the thalamus, the green fibers you can see in the diagram, then they end into the area 18, 19, the extrastriate area, visual associated area, and to MT also. While some of the fibers from the lateral geniculate body, they go to they don't go just to the striate cortex or the primary visual cortex. They rather go directly to the visual association area V2, V3, the V4 which is present in the inferotemporal lobe, and the V5 which is just in front of the parastriated cortex, the middle temporal one. These pathway they mediate the unconscious or subconscious visual functions. So the lateral geniculate body connection to the middle temporal lobe, which is called V5 area, is associated with the preservation of the motion perception in the blind field. What happens when the patient has a homonymous hemianopia or they have a complete cortical visual loss, like both of the primary visual cortex are damaged, but still they don't see the light or something, but they could still visualize the object which are moving in the field. So that is because of these preservation of these fibers running from the lateral geniculate body to the middle temporal lobe. And the fiber which are running from the retina to the superior colliculus, then to the pulvinar, and then to the extrastriated pathway, they are responsible for some of the people who do not have any complete damage to their bilateral occipital cortex, but still they can detect that some object is there, and they can even make out the shape of the object also. That is because of these alternative pathway running from the retina to the superior colliculus to the pulvinar and to the finally to the extrastriated V2 and V3 area. So now we come to the cortical visual impairment. Now we don't use the word cortical visual loss because some of these patients, they have some residual visual functions, or some time after that insult to the visual cortex, they may recover some vision. So they are not completely blind. Hence the term cortical visual loss is replaced by the term cortical visual impairment. So the cortical visual impairment is defined. This impairment results from damage to bilateral retrogeniculate pathway. That is the pathway from this pathway. This is the one from optic radiation, like the retrogeniculate optic radiation, and injury to the bilateral visual cortex. And this insult is happening either in the perinatal period or in the adulthood. The anterior visual pathway, that is the optic tract, chiasma, and the optic nerve. And the ocular structure, the eye examination would be perfectly normal in these cases. It occurs due to injury at the level of the bilateral visual cortex, or the injury may be to the subcortical fiber, like bilateral optic radiation fibers injury. Both of the injury, like bilateral visual cortex or bilateral occipital radiation injury, comes in the category of cortical visual impairment. Now, there are certain risk factors, but they are different in infant and children, and they are different in adult. Some of them, they are common in both the age group. The infant is the perinatal hypoxia or hypotension, which results into hypoxic ischemic encephalopathy. And these premature children are more prone for intraventricular hemorrhage, traumatic birth. By during the birth, there is a traumatic brain injury, or there may be a shaken baby. There's a traumatic brain injury due to the shaken baby syndrome, or there might be the patient in the neonatal age or in infancy, the child develops encephalitis, meningitis, or had hydrocephalus, and shunt was done for that, and it got blocked. Then they also result in the cortical visual impairment. Drowning also one of the factors because the respiratory arrest, hydrocephalus when the excessive dilatation of occipital horns, hypoglycemia in neonatal or infancy, inborn error of metabolism, and the congenital neurological malformation like porencephaly and lesioncephaly, schizencephaly, and prosencephaly, that is the dilatation of the cystic. These are the cystic spaces present in the brain parenchyma, and they communicate with the ventricular cavity. The epilepsy, that is a severe epileptic attack or status epilepsy, or the focus of epilepsy in the occipital lobe or near to the occipital lobe, then it's the electric discharge spreads to the visual cortex. That also results to transient cortical visual impairment. And there's a white matter diseases which are very common cause of the cortical visual impairment in the children, in the infant or in the young children, and which is called leukodystrophies. And these leukodystrophy, along with the cortical visual impairment, they have other neurological symptoms also. Now, about the risk factor in the adults is mainly the cardiac arrest, respiratory arrest, complication of the cardiac surgery, or any surgery, prolonged surgery where it causes where they use hypotension, and hemodialysis, trauma, seizure, white matter disease, which I already mentioned, but in the adult one, progressive multifocal leukodystrophy or Creutzfeldt-Jakob disease, the stroke or the posterior cerebral artery, whether happening simultaneously or sequentially, where the other neurodegenerative disorder, the common one is the Alzheimer, which is sometimes is the atypical presentation of the Alzheimer, which starts on the posterior cortical, which starts as a posterior cortical atrophy. Then some of the neurotoxin like glycine, which is used in the bladder irrigation while removing the prostate. Resection, transurethral prostate resection. The glycine is used to irrigating the bladder, or the uterine irrigation for while doing the hysteroscopy. Sometimes it results in the cortical visual impairment. So sometimes you get a reference that patient is like after that this surgery or after this procedure, the patient usually complains of complete loss of vision. Once you get this reference for like that, then keep this mind, it might be the glycine irrigation, and this is a very transient cortical visual impairment, and is a visual, and the patient improve after hours or days, gets the vision completely. Another syndrome is the PRES syndrome, is the progressive reversible encephalopathy syndrome. There are a lot of causes for that besides the autoimmune disorders, malignant hypertension, eclampsia, or pregnancy. There are certain drugs and chemotherapeutic drugs, and there are immune modulator drugs, interferon. It's a long list of the diseases and the drugs which cause. But it's a progressive, reversible in the sense it patient gets his vision in months or in few months, complete reversal of the complete regains the patient regains the vision. Carbon monoxide poisoning, another important cause of this cortical visual. Cortical visual impairment is more common in children than adult, and 25 to 50% of the children of this disease, they recover some vision, while in the adult the recovery is very less. There is a study from South India where they found that cortical visual impairment was a cause of visual impairment 33% of the cases. Cortical impairment was a cause in 33% cases of visual impairment, and out of that 33 cases, the 11% of the cortical visual impairment, they also have a associated ocular disease in the sense because they are usually preterm children, so they have a retinopathy of prematurity or the refractive or optic atrophy associated with that. So when we go for the clinical examination, the first is the history. It's important to take a history of birth of the child. Was there any birth asphyxia or any estimate history of any prematurity? Child had any neonatal period, any seizures, delayed crying, trauma. So there are these we have to, these are the factors responsible for hypoxia. Then when you examine the visual acuity, it can vary from no PL to the normal visual acuity in these children, in these patients, because though acuity is normal, but they have a visual behavioral problem or the higher visual function disorders, which we will discuss later on. And majority of the patient in the children, the visual acuity loss is quite profound, and some who have some vision, when we can in those children we can test their vision by preferential looking or Cardiff acuity test. So this is a 6 level scale which measure the visual acuity in these children of CVI. Now about the visual field in these children. The commonest one, the one who recover from this cortical visual impairment, if we can check, or the who do not have that much of insult, they have a moderate cortical visual impairment type of visual loss is there. So if we can do the visual examination in those patients, then we will find a generalized constriction of the tubular visual field or a Swiss cheese field, like a patchy area of the scotomas and the seeing and unseeing field. Hemianopia, and most of them, the children with cortical visual impairment, they have a bilateral inferior altitudinal field defect. So when you see a child who is walking with the head down, or the mother says the child trips over the obstacles when he's walking, and he finds it difficulty to walking the downstairs or jumping off the bench, then you think he might be having an bilateral inferior altitudinal visual field defect. And the children whom we can test contrast sensitivity, that is found to be reduced. And usually the color vision surprising in most of the patients of CVI, that's intact. And that is the one modality is used for visual rehabilitation of these children, because they like bright colors, especially red and the yellow. And so we use them to improve their vision or to stimulate their visual system. They have a motion, usually motion, the sensation is a moving object they will prefer, but sometimes they have a motion problem when they have a higher order visual disorders. And these children mostly prefer, or their attention is drawn mainly when the object is moving. So they prefer a moving object rather than a stationary object to look at. The other visual behavioral problems are in that they like to look at you can draw their visual attention to a simple, big, bright object, or the object which is self-illuminating one, and they do not prefer to look at the object which is a more complex one, like of the face is expression of our faces, or where there is some picture with a lot of patterns is over there. So as I told you, they have a strong color preference. They mainly for red and yellow, and that this is utilized for their rehabilitation. Secondly, the other clinical feature, there are very characteristic visual features, behavior in these children, which we should know them, because these features are used for training them and assessing their visual impairment also. So first is, as I already told them, they prefer and they like to fix over the object which is moving rather than the one which is stationary. They have a visual latency, that means they take a long time to give the visual response. Like you show them an object, they will take time to look at the object, and then you show them another one, then they also take time to move their attention from one to another. So we should be very patient and slow in examining them, and also when they are being trained. And they have a certain visual field preferences. Mainly the peripheral field is quite intact in these patients. The center field is quite impaired. And so they would like to hold the object and bring the object in their seeing area, which is very eccentric one. So their eccentric gazing is quite common. They will prefer to look at the light. So the light gazing is very common in them. And sometimes non-purposive gazing is also seen in these children. They have a they would like to hold the objects, like in the one of this picture, very close to their eyes. They would not like to look at the object which are at the distance, even though their acuity might be moderately affected. And difficulty, they would like to look at fix at the object which are more familiar to them, like a toys or a bowl or a diaper. So they would not like to look at the object which they are not familiar and do not show any visual response to them. And some of these children, because the higher visual function problem, they have a difficulty in visually guided reach. They can see the object, but when you ask them to hold the object, they would not be able to judge the distance properly, overshoot or undershooting their object. So it is difficult to judge the location of the object. So visual guided reach to the object would be impaired. As I told you, they would prefer to fix, or you can draw their attention or visual attention. They pay more visual attention to the illuminated object, toys, and that too which is moving. It's important to, whenever we are examining or the training is given to them, a single stimulus should be given, and that to be the background should be contrast background. They would prefer like black background, against that is a white toy, or white background, against that is black toy. Or the toy should be a large size according to the visual acuity of the patient, or by which we can assess them. And a single object should be given at a time, and once the patient keeps fixing over that object, then we can introduce another one. So they have another very atypical visual behavior in the form that they do not blink to the strong light and even to the threatening stimulus. So whenever you have to train them or draw them or see their visual functions, then you have to keep those objects wide separated. Do not crowd those objects, because the visual crowding or the so many things in their visual field, they lose their attention. As I told you, they prefer a high contrast, and you can draw their attention for a longer time in the high contrast objects. And the familiar objects, their visual behavior fluctuates. That's one we should keep in mind. Sometimes they would be paying a good attention and fixating and following the object. At times they may not. So we should be very patient with them. And their behavior, visual behavior, we should know, becomes worse when they are tired and in very unfamiliar environment. So every time, whenever the training is given, should be given a familiar environment, without much cluttering of the toys and not much noise around that. And it should be very quiet room, and preferably the dark room with the bright object, illuminating object would be a preferable thing. And first, when you show them an object, they look away and then they fix over that, so to bring the object into their seeing area. Some of them, they are photophobic. And the pupil examination would be normal. As you know, the pupillary fiber, they leave the optic tract and go to the brain stem. And this is the injury, this is the disease where the main insult is the optic radiation in the visual cortex. So the pupillary reactions are normal in these cases. The fundus examination in the adult CVI is mostly normal, and their ocular movements are normal. But in the children, the fundus may be abnormal if they are premature children, they have a hypoxic ischemic encephalopathy and hypotension. So they might be having ROP, optic atrophy, optic nerve hypoplasia, and they might have a large curve when there's a transsynaptic degeneration as descending down from the visual cortex, optic radiation all the way to the optic nerve. But it's a very rare. But sometimes we might get an adult one who has a large curve and has a history of CVI. Then rather than thinking of glaucoma, one should think this possibility. The children may show the oculomotor dysfunction. The adult, it may be there, but the children, they show oculomotor in the form that they have a difficulty in moving their fixation from one object to another one. They have a pursuit impairment or a hypometric saccade, or they find difficulty in tracking the object. And nystagmus is usually not a feature of this cortical visual impairment. It's usually anterior visual pathway like optic nerve, or the retinopathies is the more common. But sometimes the patient with periventricular leukomalacia can show this nystagmus. They have associated, we should keep in mind, they may have associated refractive error, which is present 50% high myopia, high metropia, and they may have associated amblyopia, which should be treated. So now talking about, these are the low order, they have a low order visual dysfunctions, which comes under the category visual acuity, contrast sensitivity, visual field, and the higher order visual cortical dysfunctions are, we divide them into three groups: disorder of recognition, disorder of the visual spatial relationship, and disorder of the awareness of vision or the visual deficit. So the disorder of the recognition, that's mainly because of the injury or insult to the ventral our visual pathway connection of the occipital lobe to the temporal, the occipitotemporal pathway insult, and that clinically manifests as acanaptopsia, alexia without agraphia, and cerebral acroptopsia, object agnosia. I will explain what these terms are, and prosopagnosia. While the visual spatial one are the acquired oculomotor apraxia, optic ataxia, simultagnosia, and visual anesthesia. The awareness, the disorder of the visual awareness was Anton's phenomena, blind side, hemispatial neglect, and redox phenomena. Now we discuss one by one. So as I told you, the disorder of the awareness of the vision. So these patients who have a higher order visual dysfunction may have a normal visual acuity, or may have a visual field defect like hemianopia, may have a normal visual acuity because primary visual cortex might be spared. It's only the visual association area are affected. So the disorder of the awareness of the vision, like Anton's syndrome, which commonly seen in the primary visual cortex insult injury. And here the patient, though can't see anything, can't move around. When he's moving around, he's bumping into the object, hitting the wall, but he still says denial of blindness. He says still he can see. When you ask what he's seeing, then he confabulates the stories about what he's seeing. Second is the redox phenomena. That's phenomena you can get in hemianopic field, and also when there's a complete visual blindness, you can also see this phenomena. Like the patient would not be able to see the object which is stationary. When you move it, he will perceive that moving object. That is called staticokinetic dissociation, and this is mainly because of the preservation of the connection of the lateral geniculate body to striate pathway, where this visual cortex is bypassed. So the visual cortex is damaged in these cases, but still they can see. They don't see the stationary one, the moving one, because of the intactness of this geniculo extrastriate pathway from lateral geniculate to the area V2 and V3. Or sometime and the blind side is another one we can get in the primary visual cortex injury, where the patient can't see at all, but can't see at all, but he can, like he cannot tell you the detail of the object, but he just can perceive that something is there. He can detect the presence of an object, or can still tell you the shape of an object. And this may be in the hemianopic field or in the completely blind patient also. And this is also because the preservation of that extrastriated geniculo-extrastriated pathway, or sometimes the injury to the primary visual cortex is not complete. There are still some area very much anterior to that visual cortex, or there are patchy insult to this primary visual cortex. So some of the intact area, they are able to detect the presence of an object, but can't see the detail of an object. So another is the hemispatial neglect or visual inattention. So the left one is the normal person. If you ask them to bisect a line, they will bisect in the middle of that. But the patient who has a visual inattention or hemispatial neglect, this is mainly seen in the right parietal lesions. So there is a most commonly you see the left visual spatial neglect or left visual field inattention. So when you give a line to the person and to ask them to bisect it, they would just ignore the left side of that line, and the right side of the line they will bisect into two. And so when you examine the patient monocularly, the field would look intact completely. Because hemianopic patient, you can't, left homonymous hemianopia, you can't talk about visual inattention, left hemispatial neglect. So when the patient is when you're examining the patient, this visual neglect patient, hemispatial neglect patient, you are examining the patient monocularly, they can see their finger properly. When you simultaneously project the field in the right and the left half of the field, they would not ignore the left. They would not say they are seeing the left half of the left side of the object. They will just keep looking and keep telling you what they see on the right half of the field. And then now we talk about the disorder of recognition, that is a ventral visual pathway disorder, which connects the occipital to the temporal lobe, inferior temporal lobe, and these are the object agnosia. Object agnosia is that when you give an object and ask him what it is, he would not be able to identify that, would not tell you, like a key bunch. You will just show a bunch of key, he would not tell you what is that. He would not be able to tell you what that object is. When you start making a sound by that, moving that, shaking that key bunch, then he will tell you that is a key bunch. So by another sensory modality like sound, or by touch, if you give in his hand, he will tell you that's a key bunch. But he would not be able to identify the object using his vision because of interruption of the pathway between occipital and the temporal lobe, where the recognition of the object occurs. But for all these higher order visual function, one should know the lesion has to be bilateral. Only the visual inattention you can get in the unilateral right-sided lesion, but most of these higher order visual disturbances are because of the bilateral visual association area insult. So, so they would not, by using the vision, cannot identify the object, but other sensory modality they will tell you. Prosopagnosia is another high visual disorder, and this is that they would not be able to recognize the familiar and their loved one faces, and even the famous personalities' faces. This can be present congenitally, or patient can develop after that the hypoxic or ischemic or stroke problems, which has to be bilateral. It is because the bilateral inferior occipitotemporal lobe, mainly the fusiform gyrus, damage or infarct. Then acantopsia is the dorsal pathway, mainly to the connection of the occipital to the temporal lobe, occipital to the V5 area. There is the middle temporal lobe, and here the person would not be able to perceive. There's a problem in perception of the motion, would not be able to judge whether the object is coming towards him, moving object, or going away, and the motion even in the depth cannot be perceived. So would the moving object will look stationary to him. Alexia with agraphia is another higher visual function disturbance. Here the patient would not be able to read the letters and the words also. But if you ask him to write down what is he seeing, he would be able to write it down. So assessment of visual acuity by a Snellen chart would be very difficult in these cases because they would not be able to read either alphabets and either the word, because the area, visual verbal area, is interrupted. So if you show him the words, he would not be able to read that out. If you ask him to write it down, what he see, that he would be able to write down this word properly. So that is mainly seen in the lesion of the splenium, the corpus callosum, along with the lesion to the left occipital lobe, as you see in this diagram, because whatever you know, the corpus callosum is a structure which connects both the hemisphere, even the same areas, homologous areas or heterologous areas. So that connects both the cerebral hemisphere or integrate our all sensory information. So whatever information from the right occipital lobe, it has to go to the left, because the left is our speech area, motor and sensory speech. So so that right area information from the occipital lobe crosses the splenium of the corpus callosum and runs into the left occipital lobe and then goes to the angular gyrus, which is present in the parietal lobe. So whenever there is a splenium lesion involving the left occipital also, so the patient would not be the information from the right and the left, both the sides of the lobe doesn't go to the angular gyrus. So patient would not be able to read the things. So whatever he's seeing, the visual verbal pathway is interrupted. So he would not be able to read it out what he is saying. And another is the higher visual is the cerebral acroptopsia. This is seen in bilateral inferior occipitotemporal lobe lesion, mainly the lingual and the fusiform. Fusiform gyrus is mainly for the facial recognition, and lingual gyrus is present in the is your occipitotemporal area and inferiorly, and it's mainly for the color perception. So these patients who have a bilateral injury to the lingual lobe, they would not be able to discriminate the color in the form. They could not match the color, and they even can't match the hue of the color. And unilateral lesion, when the hemifield, they would be hemiacromatopsia. Now we talk about the disorder of the visual spatial relationship, that is simultagnosia and failure to integrate the, like, this is a commonest cookie theft picture, Boston cookie theft picture, which is used for this assessing that on nova letters are there. So they can perceive one object at a time, but they cannot give a meaning to the whole image. Like if you ask the person about this, what he sees in the picture, he will tell you the boy, then he will say the girl, but he will not give the meaning to that. The boy is stealing the cookies, or it's a cookie type picture, or this the nova letters are there, and the E is made up of H. You ask him, then he will say H. He will not tell these are the H which makes the big E. So overall patient cannot, like if you show him a forest, he will say the tree is there, and he will say one object at a time, and he will not say this is the picture of a forest. So he can't give a meaning to the picture or the whole scene. Now there's the balance syndrome, which is a rare. It is caused by bilateral occipital lobe lesions, and it's sometimes simultagnosia may be there alone, or maybe a part of this balance syndrome. And this is seen in parieto-occipital lesions, the connection between the occipital and the parietal lobe. And then simultagnosia, this you can check it also by the Ishihara chart. He will tell you he's seeing red dot or a green dot, but would not be able to read the number written over that. Then another component of this balance syndrome is the optic ataxia. In this, the patient, the same I told you, by using the vision, patient would not be able to reach the object. If you ask him to touch this thing using his vision, he will take time to reach over there, or will misjudge the distance. And once you make the noise, with that object is making the noise, by vision he would not reach to the object, but if you make the noise that the object is making the noise, then he will correctly reach and hold that properly. Oculomotor apraxia is another one. When you ask the patient, when he's looking at one object, you ask him to look at another, but refixation movement, or you ask him to look on one side, then on voluntarily he would not be moving his eyes, but reflexively he will keep on moving his eye in different direction. So the ocular movements, and in all these apraxia, these motor functions are like optic ataxia, the limb is proper, but execution of that function using the vision would be impaired. Similarly, oculomotor apraxia, the ocular movements are normal, but voluntarily patient would not be able to perform saccades. This is also called psychic paralysis. So these patient bilateral lesion is there. They sometimes come to the ophthalmology. Their acuity is normal, but we cannot make out the diagnosis. So we have to, unless we are aware of these entities. So visual anesthesia, another condition where you see the objects looking upside down, or they are displaced on one visual field. Again, these are the occipitoparietal, because that is mainly responsible for topographic information or visual spatial perception of the objects. And this is the dorsal pathway lesion, and the ventral one, recognition. The dorsal one is spatial, visual spatial pathway. So this diagram shows the different lesions causing different higher visual functions, which I discussed already. Now they have us, these most of the children with cortical visual impairment, 75 of them have other associated neurological disorder. Hence, the rehabilitation sometimes becomes a challenging thing. They have a cerebral palsy or learning disability, microcephalic or hypotonic, and these are the other disorders they may have. Now, depending now about the diagnosis, the visual evoked responses are abnormal in majority of these cases, either in the form of increased latency, decreased amplitude, or there's a no proper waveform is there. But some of them, they on the flashlight, flash VR, some of them may show normal VER. So the presence of normal VER doesn't rule out the presence of cortical visual impairment. And the cause of this intact VER, because of this again, extragenicular striate visual pathway. And now the neuroimaging is a very much important modality for diagnosis of these children, as that helps not to see in seeing what extent the injury or insult has happened to the brain because of hypoxia or hypoperfusion, and also the location of the brain damage also. So the MRI is a better modality than the CT, and MRI should always be performed in the children with a lower Apgar score, as it gives you an idea about the prognosis and we can also get an idea whether how much vision recovery chances are there in these children. Sometimes MRI may be normal in these cases, especially in the acute phase in the adult one, when there is a bilateral occipital infarct is there. So in the adult one, the MRI, if you just do it within an hour, may be normal. So in those cases, the diffusion weighted imaging and MRS, the magnetic resonance spectroscopy, helps us in making whether this infarct is there or not in making the diagnosis. MRI changes in cortical visual impairment children may be in the form of periventricular leukomalacia, and which is mainly seen in preterm children, and diffuse cerebral atrophy, multicystic encephalopathy. In acute brain injury, MRI, I said just MRI may be less sensitive, and these two modality of imaging would be very helpful. And it depends upon the pattern of the MRI, changes depends upon is the preterm or a term child. And it also depends upon the severity of the hypoxia or hypotension, the duration, and the degree of maturity of the brain. The preterm, what changes we get is the periventricular white matter. And while in the term, is the parasagittal watershed zone areas are more affected because of the hypotension between the anterior cerebral artery or middle cerebral artery. So there would be infarct in the frontal lobe, and when the posterior the watershed zone or and the area between the middle cerebral artery and posterior cerebral artery is that seen in the adult one, and in the term babies, these signal changes would be seen in MRI. Now about the prognosis and management of these cases, it depends upon the cause of the insult and the extent of the injury to the visual cortex and the adjoining visual association areas. There might be complete loss of vision, then the improvement is very rare. It's very important to understand in these children that the early intervention of these cortical visual cases is very important. So the visual rehabilitation should be done early, as neuroplasticity is maximum in these first few years, or up till the age of 3 years, it's a maximum over there. And we should prevent the premature birth of these children, or a proper neonatal ICU should be there. And the cooling is one of the things which reduces the insult of these children to the brain because of the hypoxia or hypotension. So now about the managements, and as I said, the majority of the cases of cortical visual, cerebral visual, cortical visual impairment children, majority of them, they show some improvement in their vision. It would not be the normal, but they at least regain some vision, that they can move around, navigate properly, or can locate the objects. The vast majority of the children, like 25 to 50%, recover some vision. And there is the visual acuity, and in the cerebral visual or cortical visual impairment children, there are two things. There is the visual function and functional vision. Visual function includes visual acuity, color vision, contrast sensitivity and visual field. While functional vision is whatever the vision is there in the child and how he's using in day-to-day activity and in their daily activity. So there is a certain range of cortical visual impairment. The range is there, which is described, which is given by Roman Lanzi, and this range is divided the cortical visual impairment in these children from 0 to 10 phase. 10 phase is totally normal one, and 0 they were don't see at all. So they are 0 to 3 are the mild and the moderate and the severe one. And according to their the range of visual cortical visual impairment, the visual rehabilitation given in different phases, like 0 to 3 the phase 1, and the 0 and 3 to 7 they give the phase 2 type of visual rehabilitation, and phase 3 the who have a slightly better vision. And the one is given to the way who do not locate the light, and if they locate the light do not pay attention for a longer time. The one two is the one they can locate the line and can they show some visual behavior and look at the object for some time, but how they use that vision in their day-to-day activities is taught to them in the phase 2. And phase 3 the refinement of their skill. So about the management of the adult cortical visual impairment patient is that given is the visual substitution therapy, compensation therapy, and visual substitution therapy is that we use the spectacle, we use the prism like personal plastic prism in the spectacles of this patient. So the objects from from the blind field will move to the seeing area, and these prisms are given to the hemianopic site, and the base is facing towards the site of the hemianopia. And second is a compensated patient is taught to move their head and the eye, like to perform the saccade and the head movement towards the blind side. Like they have to increase their saccadic or number, like increasing the frequency, and they have also the increasing the amplitude of the saccades and the head movement towards the blind side. That helps also in their reading, day-to-day reading, and avoiding the obstacle. The wayfinding, they are taught how to use that cane and also the guiding dogs. If the patient have the left homonymous hemianopia, he will find difficulty like once he finish one line and then going back to the then restarting from the new line, he find difficulty. So they have to use the ruler. If they use the ruler and put it under the line and gradually move, that helps in them in reading the material. While right harmonious hemianopia patient, they find difficulty from once they have read one's lecture, then move to the another lecture. For that, they say some of them they use this inversion telescope or and make them to read better from we read from left to right, make them to read from right to left side. And the people who have a bilateral homonymous hemianopia because of simultaneously PCA occlusion or sequential, and where there's a macular sparing, so they have a tubular field of vision, there their visual field can be enhanced or visual performance or reading can be enhanced by giving them reverse Galilean or Kepler type of telescope. So the just few words about the delayed visual maturation, because these are the children where they mimic the cortical visual impairment children's, but this is the entity where they have a good chance of recovering their vision, and is thought to be one of the spectrum of CVI, results from preemptory dysfunction of the higher cortical center, and visual in the beginning the child would not be responsible to visual stimulus and will not pay any visual will response to the visual object. And but as the time goes and the training is given, or the time goes and is mature, or he grows by the period of 6 months or 1 year, it improves completely and regains his full vision. In these patients, neuroimaging and electrophysiological tests are normal, but some of them they may have associated neurological abnormality. Another entity which we should know in this cortical visual impairment is the posterior reversible encephalopathy, the PEP syndrome, which is a rare one. Mainly it is because the bilateral parieto-occipital lobe lesions and the common causes, as I already told you, and there are certain drugs, autoimmune diseases, and this is an acute condition associated with some neurological disorders also, and the main pathogenesis is because of this. All these disorders, they cause they impair the blood-brain barrier in the parieto-occipital area. They the blood vessels, they start leaking, and so there is a impaired permeability of the blood vessels in the parieto-occipital area. So there is a vasogenic edema or edema to the surrounding tissue, surrounding cortical areas also. So there is a transient cortical visual impairment which lasts for months. The patient recover completely. Most of them, they recover completely. Some of them might not recover completely. MRI is very typical and very helpful in making this diagnosis. There would be symmetry to hyperintensity because of the vasogenic edema, and that would be in parietal and occipital lobe. But that's all, and I finished my presentation now.
Okay. Thank you.
So any questions?
Thank you, ma'am, for that exhaustive lecture on cortical visual disorders. We have covered everything. Not much is left for the discussion. I think this is the last lecture of the Neuro Ophthalmology and Strabismus module today.
Okay.
So I think Pranita ma'am is there.
Yes, yes, Gunjan, and we are really thankful to ma'am for that extensive lecture on this difficult topic, which is usually not covered in classes and not really very well described
Gunjan
in
has
books
written
as
an
well.
article.
Yes, yes, but
In
today,
iWiki. Yeah.
yes. So today we were on the last session of our neuro-ophthalmology and strabismus module, and I think we have had a great lecture from ma'am on this topic. And sir is also there. Dr. Praful is also there today. Sir, you want to make any comments?
Thank you so much, ma'am. And in fact, it improved my knowledge also. Cortical blindness, at times we simply write it, but we never understood this in the way the way you taught to us today. And I think that is the special thing about all the RPC alumni who have gone out. They have excellent teaching acumen, and whatever they teach, that is really helpful to all of us. And thank you, mom, for being a part of this. And you gave a right ending note to our PEP series. And to the students, we'll be back very soon. There will be little gap because there are some issue with the platform that we were using. So we'll be jumping onto a new platform, and that will take some time. And the PEP group, I am switching to all can message. I request you all to send me which module you want. We have already done the plasty and retina module. Next module, you people decide the top difficult section that you feel should be covered by DOS PEP. And with that, ma'am, this is a small appreciation from us. And ma'am, I request you to join us in our annual DOS meeting, which will be in April 24, 25, 26. Yeah. And you please let me know. You can share some topic if you want to. And for the first time, we have started instruction courses. You can submit some instruction courses also. I will sharing the link. And Gunjan, if there are no questions, then we can conclude here.
Yes, sir, we can conclude the lecture for today.
Okay, thank you. Good night.
Thank you.
Thank you so much, ma'am. Thank you, everyone.
Thank you. Good night.
Thank you, Gunjan, for taking out time for this entire series and being with us for all the sessions that you have moderated. Thank you so much. Thank you, ma'am, for taking out your valuable time, ma'am.
Okay, thank you. Bye.
Thank you.
Bye.